What if I told you that vast portions of our country are hours away from their nearest health system and sometimes even hospital? Rural America is often seen as the backbone of our country, and yet rural health care remains a challenge. But what is that challenge, and what are rural hospitals across this country doing to make sure every American can get the health care that they need? Rachel Lott of Hillsdale Hospital and the podcast Rural Health Rising joins us to discuss those questions and more. That's all coming up right here, right now. I'm Sam Chen, and this is Face the Issues. Good evening and welcome to Face the Issues. I'm Sam Chen. For millions of Americans across the country, medical care may not be just a quick few-minute drive away. While health systems and hospitals across the country have had great success, much of rural America remains challenged by some of these healthcare practices, where health systems don't reach and sometimes hospitals are sparse. And this is where the rural hospital and rural health care comes in. Rachel Lott serves as Director of Marketing, Development, Community Outreach, and Government Affairs at Hillsdale Hospital. She's the co-host of the podcast Rural Health Rising that addresses questions like these. And she's our guest this evening. Rachel, welcome to Face the Issues.
Hi, Sam. Thanks for having me.
Thank you for being here. This is a great pleasure for our viewers who don't know. Rachel and I have known each other for years. I recently had the privilege of being a guest on her podcast, which is very, very well worth listening to, and a much better show than anything I could do here. So, Rachel, I appreciate you changing roles today and joining me on the show.
Yeah, absolutely. And if you want to go hear Sam, there is a really great episode. We talk a lot about healthcare policy on Rural Health Rising. So
it's a great podcast. I highly recommend it. Rachel, let's jump in here. When we talk about rural healthcare, it's a term that you can kind of piece together, right? It's healthcare in rural America. That's in many ways a no-brainer. But what is rural healthcare? What defines rural America? Who are you serving?
Right. So, rural hospitals can be in very sparsely populated communities that maybe are not too terribly far from larger areas, or they can be in locations that are significantly geographically isolated as well as sparsely populated. But for us, we know that since 2010, more than 130 rural hospitals in America have closed. And to define rural, there are a lot of different ways you can look at it. There are, governmental definitions typically of what rural areas are. A lot of times it's based on census data and that kind of thing. But when we talk about rural healthcare, there are rural hospitals, there are rural emergency rooms, maybe that are standalone because that community no longer has a full service hospital. Then you also have rural healthcare providers. So these are physicians, advanced practice practitioners, folks who may be independent and not associated or employed with a hospital in particular, and all of the above, and also maybe a combination of those things.
Rachel, I want to touch on something you just brought up, something that I don't think most Americans realize. You just mentioned rural emergency rooms because the hospital in that region has closed. So I think for most of us that live in suburbia or in the urban setting, we think of an emergency room as directly attached to a hospital. You're saying that there are parts of America where there are no hospitals within reach and there are standalone ERs.
Yes, there are. And it's funny, in the last probably 10 to 15 years, you see some more standalone ERs in larger communities as well, more as a business model. But in rural America, the emergency room, the difference between having one and not having one is the difference between life and death for a lot of individuals. But that is truly a stopgap measure, whereas really rural communities need more than just emergency rooms. We find there are rural hospitals that could be hours away from another larger hospital. There could be people like in our community here in Hillsdale, Michigan, we have a county of about 45 to 47,000, depending on what year you're looking at the information. But with that, we have another hospital maybe 35 minutes away from here, but it's another small rural hospital in an adjacent county. And then the next larger hospital in the state of Michigan is about 45 minutes away, which doesn't sound far for some, but when you recognize that rural populations are typically significantly more poor and also older than other areas, transportation becomes an issue, and transportation is actually one of the #1 issues and #1 barriers for individuals accessing the healthcare that is in their community. So, we have a large Amish population here as well. So when you think about someone who it's difficult to even get here to our hospital in their own county, having to leave the county or drive 45 minutes to get to a hospital, it just can't be done, especially for things like chronic health conditions, health maintenance. That's not really happening for folks if they don't have local access to healthcare.
And that's the other thing you just touched on, the idea that you are in Michigan. I think when most people think Michigan, they don't necessarily think rural America. When we say rural America, we think Nebraska, we think Iowa, we think people who live among corn. Michigan, we typically think University of Michigan Health System, Michigan State University, things like that. It's same thing in my home state of Pennsylvania. I think people typically think Penn, Jefferson, Penn State Health, or Pittsburgh. And yet in states like Michigan and Pennsylvania, there are large areas of rural America and the need for rural hospitals. What are you seeing in your work, Rachel, in Michigan, in the Hillsdale area about this need for rural healthcare?
Well, for us, one of the things that really impressed me about Hillsdale Hospital before I started working here, I actually live in Indiana, and I drive through Ohio and into Michigan every day to work because of the incredible organization here. But Hillsdale Hospital is an independent community hospital. And so what we find is that locally governed healthcare is often the best healthcare because it is the most responsive to the needs of its community. So for us, we have a very comprehensive continuum of care here in Hillsdale. We have primary care. We have a lot of specialty care that we've brought in. Sometimes that's specialty care that we own and operate ourselves. Sometimes we bring in partnerships with other physicians or maybe other healthcare organizations in order to make sure that as much care is accessible locally for our community as possible. So, we have a behavioral health unit here at our hospital, and that is a hugely important service when you think about the shortage of mental health care beds across the country. The fact that we have that right here in our own local rural community, it's really important. And that's one of the things that it's not necessarily a moneymaker for the hospital. For most hospitals, it's not a moneymaker. That's why a lot of places have closed behavioral health units over the years. But we know that that's important for our community, and it's a necessary health offering. And so we take the loss and make it up somewhere else because we know it's absolutely critical to our community to have that kind of service. Obstetrics is the same way. When a lot of rural hospitals and rural communities are closing their obstetrics unit because they typically lose money on obstetrics, especially when you have a higher Medicaid population, which is typical of rural communities, Hillsdale Hospital built a brand new birthing center not too many years ago. And let me tell you, it is beautiful and state of the art and incredible. And so for us, we really focus on, not selling ourselves short just because we are rural and we are smaller. We are independent, but we're also interdependent. So we build as many partnerships as we can to the benefit of our patients and so that we can, continue to reinvest in our hospital, our equipment, and the care that we're able to provide.
Rachel, what do you see as the greatest challenge for rural healthcare? I mean, the sense of obviously large hospitals, health systems in major cities, in many ways that there's a logic to this. When there's so many people in the city, you need the systems. Some cities, it takes an hour to drive through the city. And so you're going to need hospitals in multiple parts of the city. But they also end up with a large piece of the funding. As you mentioned, a lot of times that some of the units that are being cut from other hospitals are being cut because they're not money makers. And yet rural hospitals are trying to expand on them and reinvest in them. I can't imagine that's making rural hospitals money. What are some of the big challenges that you see in rural healthcare? Let's talk pre-COVID, because I think COVID gave everybody healthcare a challenge. Pre-COVID, what are some of the big challenges that you have seen?
Right. So one of the major issues is just the nature of the way that our healthcare system works in terms of payment and reimbursement. So for rural hospitals, typically you're going to see a significantly higher proportion of what we call our payer mix. So the payers which we are getting our reimbursement from. So for us, 70% of our reimbursements are Medicare and Medicaid. So that's through serving those patients. Now, in larger communities, that's a much smaller percentage. So with that, the challenge is that our commercial insurance base it doesn't even make up the rest of that 30%. It's just a portion of that. So we're a smaller hospital. We only have so many patients or covered lives, as an insurance company might refer to them. And so when it comes to negotiating for better rates from the insurance companies to reimburse us for the care that we provide, we don't have a lot of bargaining power. Whereas when you have a large health system that's maybe also acquired a bunch of other hospitals and other communities, they have a much bigger number that they can use to bargain with to say, hey, we have, 300,000 covered lives, or we have 1 million covered lives. And so it's a lot easier to go to that commercial insurance provider and say, hey, we actually want you to pay us this for this service as opposed to this. And so they can leverage that. We don't have that luxury and that flexibility. So in addition to that, with our commercial insurance, which again makes up a small percentage of our total reimbursement, the rest of it is Medicare and Medicaid. So Medicare pays us usually a little more than what it costs us to provide the care. Medicaid, often we either break even or we lose money on Medicaid reimbursements. And so with that, you then have this situation where, because of the nature of where we are physically located, the population we serve is typically more likely to be a Medicare or a Medicaid patient, by and large, obviously not everyone, but a significant portion. It's a lot harder to have a margin when you're serving that much of your population with Medicare and Medicaid. So, the goal in rural health often is to break even, believe it or not. So when rural hospitals are in the black at the end of the year and maybe have a little bit of money on the balance sheet, that's a pretty big deal. A lot of rural hospitals are losing money every year, and eventually that money runs out. Whatever cash on hand they may have gets depleted and depleted and depleted to the point that they can't make payroll and they close their doors. And that's what we've seen for more than 130 rural hospitals since 2010. The number keeps growing. I believe the last I checked this year was around 136. But when you think about that, you think, okay, well, a hospital closed. Well, what happens in a rural community when their hospital closes is that you lose what is typically the largest or maybe second largest employer in the city and sometimes also in their county. So you lose that in terms of your local economy. You also lose the buying power that hospital has working with local businesses as its primary vendors for services and supplies that it needs. And also you have a hard time attracting any additional employers to a community where healthcare is not available. So often what we see is hospitals close and then the communities start to die or start to, their population depletes even more than it already has, because we do see, of course, in rural communities, often populations have been shrinking, and that's a whole nother episode to think about. But that's really the environment that we operate in. So the biggest challenge is that all of these pieces coming together don't really put us in a great position to have long-term financial sustainability without really getting creative and really getting smart and strategic about what we're doing. But we're also doing that with less resources, fewer staff. As you can tell from my very long title, we all wear a lot of hats in rural health. We do a lot of work as individuals, and so we're stretched pretty thin. So we really have to be strategic and smart about how we get things done, and make tough decisions about how do we make sure that our patients have access to the services they need.
And the impact, of course, would be everybody in that community. So, Rachel, thank you for that insight. When we come back, I want to talk about some of the solutions to these challenges and, of course, how rural hospitals dealt with the COVID-19 pandemic. So don't go away. We'll be right back. Welcome back to Face the Issues. Rachel, thank you again for being with us. I want to pick up right where you left off. And one of the challenges that you talked about with rural healthcare was the idea that a lot of your patients are Medicare or on Medicare or Medicaid. And as a result, the hospitals reimburse less per dollar spent. And oftentimes your rural hospitals, if they can make it to the black at the end of the fiscal year, that's a huge accomplishment. This is something that hospitals and health systems, whether in rural areas or not, throughout America have struggled with because of COVID-19. This is something that you saw all the major health systems start talking about COVID challenges, and with everything else, with all the other procedures on hold, they only had majority Medicare, Medicaid patients that were dealing, the older population coming in for COVID issues. And they saw this reimbursement challenge. So they got a little bit of a taste of what you guys deal with every single year over this last year and a half. I want to ask you, how did COVID-19 hit on rural hospitals? What was that experience like? Because I don't think we hear a lot about that.
Yeah, it's been interesting. So for us here in Hillsdale, initially, we really didn't see a whole lot of COVID. In the spring of 2020, we did have cases, but we weren't seeing a ton of hospitalizations. We didn't really have what I would call a significant number of COVID-19 inpatients until December of 2020. But if you remember, right in March, in the beginning, when things kind of started, we had our first case here, middle of March in 2020. And, a lot of states, Michigan included, shut down elective surgeries for their hospitals. And what that meant for us was a $10 million loss in revenue during the time period that was shut down, which was for a couple months. Now, at the time, we had no COVID in our hospital. We didn't have any of our employees test positive for COVID until months later, who had been working. And so, we really felt like, we've done a great job of keeping COVID out of our hospital, yet our patients can't receive the care that they need, because when you shut down elective surgeries, the term elective can be deceiving. Elective doesn't mean, it's a facelift that's purely optional just because you feel like it and you want to. Just because something is elective doesn't mean it doesn't have health implications the longer you delay it. So even now, we still have patients that we are catching up who were not able to get their surgeries and their procedures done back in the beginning. So then, of course, now we get to this stage in the pandemic where it's been, 18 months now. We're going on 2 years here, coming up close. And we have seen a shortage in healthcare workers across the country. Hillsdale Hospital is no stranger to that. We've not had to shut down any of our services. We have seen hospitals near us that have had to shut down entire floors due to staffing challenges. But we do have fewer staff than we would have had before. For a multitude of reasons, lots of turnover, and then we have open positions that we're working hard to fill. And so what happens is now we have had a lot more patients. We have a very low vaccination rate here in our community. We're running at about 40% of our community is vaccinated in Hillsdale County. And so that leads to more infections and more hospitalizations. And so we've started tracking that and posting that information publicly for our community to see how many COVID-19 hospitalizations have we had and how many of those folks have been vaccinated, how many have not. And the numbers really show that vaccination makes a huge difference in survival rate, in the likelihood that you're going to end up in the CCU on a ventilator or in the hospital at all. So, just the last several weeks, we have seen our highest numbers to date since the pandemic began here in Hillsdale, and other rural communities are seeing it hit now as well. Really, for maybe the first time for some, for us, it's kind of the second time it's worse than it was when we kind of had that first, I guess you could call it a surge, which I don't know if there's a technical term for that. So I hate to use that word because it's a little subjective. But we saw that our first kind of real increase was December of 2020. But, over the summer, we had times where we went more than 30 days at a time without any inpatients who were hospitalized due to COVID-19. Now we're seeing frequent admissions. Fortunately, today we're back down to, I think we have about 8 patients in our hospital at the moment who are hospitalized due to COVID-19. But, there were times in the last couple of weeks we were at 20. And for us, that doesn't sound like a lot, but for us, that is a lot. We only have 6 beds for critical care, 2 of which are step-down beds that can be used as critical care as needed. So, it's really hit us hard now. And we're concerned when it comes to staffing that we can keep all of these services open for our community. That's what we're really focused on. But also, with potential vaccine mandates, that's also a risk.
Yeah, let's talk about that. The vaccine mandate. You just said that the numbers that you guys are looking at shows that the vaccine is effective, the vaccine is working, and yet the 40% of Hillsdale County vaccinated. It's not a high vaccination number. Talk to me about what the thought process is, where Hillsdale Hospital is on the vaccines. Why is that number low? And what do you make of the vaccine mandate? Knowing full well, and our viewers should understand this as well, you can be pro-vaccine and have serious concerns with the mandate. But talk to us through that process from a rural hospital's perspective.
Yeah, so the issue we face is that, rural communities tend to be more politically conservative typically. And what we've all seen across the country is that the issue of vaccination has been politicized. It's kind of been hijacked to be a political conversation, which it is not and it shouldn't be. And political ideology is being exploited as a way to really just build hype on one side or the other, in one direction or another, which is great for the people who that is their living, is doing those things and talking about that and having these extreme issues be a big deal and be discussed and building these followings based on all of that. But the reality is this is a healthcare issue and a healthcare decision, not a political one. Unfortunately, your healthcare workforce typically reflects your community, right? So in Hillsdale, when we have a typically more conservative community, the more political the issue becomes, the easier it is to kind of draw those lines between vaccination rate and political feelings and beliefs. So with that, we fortunately do have a much higher vaccination rate with our staff than we do with the community, so that's good. But we are not in a position where if a vaccine mandate comes down the way we expect it to from CMS to not have an option for weekly testing, that is different from what we expect OSHA to put out for non-healthcare employers with more than 100 employees, that we, as far as we know, will have an option for weekly testing. Healthcare won't have that. So we're going to be in the position where we have to tell our team, we don't have the choice to continue employing you if you aren't vaccinated. So what we're concerned about is we're in a community where in rural America, people are twice as likely to die of COVID than they are in other areas. So that's a problem. We also are smaller hospitals. We're more rural, so we have less resources. We often run on much leaner teams in the first place. We don't have a really deep bench. So then when we have this situation where, some of our staff who have deep convictions about this are going to end up having to remove themselves from the healthcare industry without another option like weekly testing, we're not really sure what position we're going to be in. So we're in the process of having really open dialogue type of conversations with our staff. Our managers are speaking to our staff directly to say, hey, how are you feeling about this, so that we can start to navigate that as a team and not be in an us versus them mentality, because we don't support a federal mandate because we don't believe that that is the best way for us to continue taking care of our patients and our community and providing the health care that's needed. If we have staff who leave, if we have a large number of staff who leave due to a vaccine mandate, then again, we're in a community where we have a low vaccination rate. We're rural, so people are twice as likely to die of COVID if they do get it. And now we have even fewer healthcare workers, so there's not enough healthcare to go around. We could really be in a scary position for our residents here who just are sick and need healthcare.
And it's an interesting catch-22 in some ways, because you want people to get vaccinated. From what I'm hearing is you want people to get vaccinated because it is such a dangerous virus, especially in rural areas. And yet, on the other hand, a mandate could eliminate key healthcare workers that you would need in order to combat the virus and other potential medical issues. And so it seems like there's an odd catch-22 that you and other rural hospitals have to face.
There is, because, those two things don't actually have to be in conflict with each other. So believing that the vaccine is effective and it is the best option, and that is what we are asking people to do. Every single week we do a Facebook Live with our community, and we are telling people, please get vaccinated. It is so important. We believe it's the right choice to make, but we also recognize that that is the choice of individuals. And so to then have a mandate that takes that choice away from them could put us in a position where, at some point you have to ask yourself, is it better to have a healthcare workforce partially unvaccinated or to have a healthcare workforce that is not sufficient?
That is certainly a challenge. Rachel, thank you again for your insights. Don't go away. We'll be right back. Welcome back to Face the Issues. Rachel, thank you again for joining us and for your insights. I want to close out. What we like to do on this show is get to know our guests a little bit. These are hard questions. These are hard-hitting issues. These are real issues. But all of our guests are people who have their families and their lives, and there's always a reason you do what you do. So I want to start just with that question. I mean, I've known you a long time. We were in school together at Baylor. But what's your why? You drive from Indiana to Michigan every day to work in rural healthcare. What is your why? What gets you up in the morning?
You know, for me, I was just talking to a colleague about this today. I've always really needed that emotional paycheck to be part of my work and my career. I get a lot of fulfillment out of the work that I do. It's very important to me. But if I don't feel deeply emotionally connected to the work that I'm doing, it's a lot harder for me to motivate myself and be engaged in the work that I do. So in rural healthcare, you know, we are kind of the underdog, and I kind of like that position, to be in that kind of underdog position of, you know, people don't necessarily expect a lot from us, but watch what we can do kind of approach to things. So I love that. I want to be a person who at the end of the day, I can feel good about the work that I've done and how it's going to make a difference in the lives of individuals. And, you know, we have an incredible team that works so hard day in and day out to take care of their neighbors, their family members, their friends here. And for me to be able to do the work of supporting them, but also with marketing, I just get to brag on the great work that they do, which is such a privilege and such a pleasure that I get to show our community and surrounding communities how incredible the team is at Hillsdale Hospital. I mean, it's giving me chills just talking about it, because these people are incredible professionals. They do incredible work, and there's just so much heart in what they do and in our team here. And I'm just grateful that I get to be a part of it.
Well, Rachel, thank you for sharing these stories with us. And thank you so much for being here today. We really appreciate it.
Thanks for having me.
That is our show for tonight. I want to thank Rachel Lott from Hillsdale Hospital for joining us. And thank you for tuning in. We hope to see you right back here again next week. Until then, my name is Sam Chen. On behalf of all of us here at Face the Issues, thank you and good night.